The hematopoietic system is like a busy factory inside your bones. Its main job is making all the blood cells your body needs to work correctly. This factory is located in the bone marrow, the soft, spongy tissue found in the center of most bones. Think of it as the central command for blood production. Every single day, this system produces billions of new cells to replace old or damaged ones. This constant renewal is essential for life. Without it, our bodies could not transport oxygen, fight infections, or stop bleeding. Understanding this system is fundamental for any family nurse practitioner because, honestly, many common patient complaints can be traced back to a problem in this blood factory. There are three main types of blood cells produced: red blood cells, white blood cells, and platelets. Red blood cells, or erythrocytes, are the oxygen carriers. They contain a special protein called hemoglobin that grabs oxygen in the lungs and delivers it to every other part of the body. White blood cells, or leukocytes, are the soldiers of your immune system. They are your body's defense force, fighting off bacteria, viruses, and other invaders. Platelets, or thrombocytes, are the first responders to an injury. They rush to the site of a cut or wound and clump together to form a plug, which is the first step in stopping bleeding and starting the healing process. Anemia is a condition where you do not have enough healthy red blood cells, or your red blood cells do not have enough hemoglobin. When this happens, your body's tissues and organs do not get the oxygen they need to function properly. This can lead to a wide range of symptoms, from feeling tired all the time to more serious issues like shortness of breath or an irregular heartbeat. As an FNP, you will see anemia frequently in primary care. It is not a single disease, but rather a sign of an underlying problem. Your job is to be a detective, figure out the cause of the anemia, and create a plan to fix it. To understand anemia, we look at the size and color of the red blood cells. The mean corpuscular volume, or MCV, tells us the average size of the red blood cells. If the MCV is low, less than 80 femtoliters, the cells are small, which we call microcytic anemia. If the MCV is normal, between 80 and 100 femtoliters, it's called normocytic anemia. If the MCV is high, greater than 100 femtoliters, the cells are large, which we call macrocytic anemia. The mean corpuscular hemoglobin concentration, or MCHC, tells us about the color, indicating how much hemoglobin is in each cell. Low MCHC means the cells are pale or hypochromic. These clues from the complete blood count are the first step in solving the mystery of why your patient is anemic. Iron deficiency anemia, or IDA, is the most common type of anemia worldwide. It happens when your body does not have enough iron to make sufficient hemoglobin. Hemoglobin is the protein in red blood cells that is responsible for carrying oxygen, and iron is its most crucial building block. Without enough iron, the bone marrow factory cannot produce enough hemoglobin. As a result, the red blood cells it makes are small and pale. They are called microcytic and hypochromic. Think of it like trying to bake a large batch of cakes but running out of flour. You can only make a few small, flat cupcakes instead. This is exactly what happens to your red blood cells in iron deficiency anemia. So, who is at risk for iron deficiency anemia? The risk groups are quite broad. Women of childbearing age are at high risk due to blood loss during monthly menstruation. Pregnant women are also at high risk because their iron needs increase significantly to support their own blood volume expansion and the growing fetus. Infants and young children, especially those who drink a lot of cow's milk, which is low in iron, are another key group. Older adults may be at risk due to poor diet, chronic diseases, or gastrointestinal bleeding. Vegetarians and vegans can also be at risk if they do not consume enough iron-rich plant-based foods. Basically, anyone with chronic blood loss, poor iron absorption, or increased iron needs is susceptible. The signs and symptoms of iron deficiency anemia develop slowly and can be subtle at first. The most common complaint is fatigue and weakness. Patients might say, "I'm tired all the time no matter how much I sleep." Other symptoms include pale skin, especially in the palms and conjunctiva of the eyes, shortness of breath with exertion, and dizziness. Some people experience headaches or feel cold all the time. A classic, though less common sign is pica, which is a craving for non-food items like ice, dirt, or clay. You might also see spoon-shaped nails called koilonychia, or cracks at the corners of the mouth, known as angular cheilitis. Key lab findings are essential for diagnosis. The complete blood count will show a low hemoglobin and hematocrit. The MCV will be low, which means microcytic, and the MCHC will be low, which means hypochromic. The most specific tests, though, are the iron studies. You will see a low serum ferritin, which is the best indicator of the body's total iron stores. Serum iron will also be low. The total iron binding capacity, or TIBC, will be high, which means there are many empty seats on the transport protein, transferrin, waiting for iron that isn't there. This combination of low ferritin and high TIBC is the hallmark of iron deficiency anemia. Anemia of chronic disease, also called anemia of inflammation, is the second most common type of anemia. It occurs in people who have long-term medical conditions that involve inflammation. This can include chronic infections like tuberculosis, autoimmune diseases like rheumatoid arthritis or lupus or cancer. In these conditions, the body's inflammatory response messes with how the body uses iron. The body has plenty of iron stored away, but it cannot access it to make new red blood cells. It's kind of like having a full pantry of food, but losing the key to the door. The iron is there, but it is locked up and unavailable for hemoglobin production. The main mechanism behind anemia of chronic disease involves a hormone called hepcidin. During chronic inflammation, the liver produces high levels of hepcidin. This hormone acts like a gatekeeper, blocking iron from being absorbed from the gut and preventing it from being released from its storage sites in the liver and macrophages. This sequestration of iron leads to a functional iron deficiency, even though the body's total iron stores are normal or even high. Because of this, the red blood cells produced may be normal in size or normocytic at first, but over time they can become small or microcytic as the iron restriction continues. Patients with anemia of chronic disease often have symptoms that are masked by their underlying chronic illness. The fatigue, weakness, and general feeling of being unwell from the anemia can be hard to separate from the symptoms of their primary disease, like the joint pain of rheumatoid arthritis or the systemic effects of cancer. The symptoms of anemia itself, such as pallor, shortness of breath on exertion, and dizziness, are the same as in other anemias. However, the onset is usually gradual, and the severity of the anemia often correlates with the severity of the underlying inflammatory condition. The key is to consider anemia of chronic disease in any patient with a known chronic inflammatory disease who presents with anemic symptoms. The lab findings for anemia of chronic disease can be tricky and are what distinguish it from true iron deficiency anemia. The complete blood count will show a mild to moderate anemia, which is often normocytic and normochromic, meaning normal MCV and MCHC, although it can become microcytic over time. The key difference is in the iron studies. Unlike in iron deficiency anemia, the serum ferritin will be normal or high, indicating that the body has adequate iron stores. However, the serum iron will be low because it's all locked away. The total iron binding capacity will be low or normal, showing that there are not many empty seats for iron transport, which is the opposite of what you see in iron deficiency anemia. Folic acid, also known as folate or vitamin B9, is another essential ingredient for our blood factory. It is crucial for DNA synthesis, the process of making new cells. When the body does not have enough folic acid, the bone marrow cannot produce red blood cells properly. The cell division process is impaired, so the cells that are produced are very large and immature. These large red blood cells are called macrocytes, and this type of anemia is called macrocytic or megaloblastic anemia. These oversized cells are also fragile and do not live as long as normal red blood cells, which contributes to the overall shortage of healthy red blood cells in the bloodstream. The most common cause of folic acid deficiency is inadequate dietary intake. Folic acid is found in leafy green vegetables, citrus fruits, beans, and fortified cereals and breads. People who do not eat enough of these foods, such as some older adults with poor appetites or individuals with alcoholism, are at high risk. Another major risk group is pregnant women, whose need for folate increases dramatically to support the neural tube development of the fetus. This is why prenatal vitamins are so rich in folic acid. Certain medications like the seizure medicine phenytoin or the antibiotic trimethoprim sulfamethoxazole can also interfere with folate absorption and lead to a deficiency. The symptoms of folic acid deficiency anemia are similar to other anemias. Patients will complain of fatigue, weakness, and shortness of breath. They may appear pale and have a sore, red, and smooth tongue, a condition called glossitis. They might also experience mouth sores or changes in their sense of taste. One very important distinction is that folic acid deficiency does not cause the neurological symptoms that are seen in vitamin B12 deficiency. This is a critical point to remember for your FNP exam and in clinical practice. The absence of neurological signs like tingling, numbness, or balance problems helps differentiate it from pernicious anemia. When you order a complete blood count for a patient with suspected folic acid deficiency, you will see a low hemoglobin and hematocrit. The defining feature is a high MCV, greater than 100 femtoliters, indicating that the red blood cells are macrocytic. You may also see a low reticulocyte count, as the bone marrow is struggling to produce new cells. To confirm the diagnosis, you will order a serum folate level, which will be low. It is also standard practice to check a vitamin B12 level at the same time. This is because both deficiencies cause macrocytic anemia, and you must rule out a B12 deficiency before starting treatment with folic acid alone. Pernicious anemia is a specific type of vitamin B12 deficiency anemia. It's actually an autoimmune condition where, unfortunately, the body's immune system mistakenly attacks the cells in the stomach that produce a protein called intrinsic factor. Now, intrinsic factor is essential for the absorption of vitamin B12 from the food we eat. Without intrinsic factor, your body really cannot absorb B12, no matter how much you consume in your diet. Like folic acid, vitamin B12 is vital for DNA synthesis and the creation of healthy red blood cells. A lack of B12 leads to the same production problems in the bone marrow, resulting in large, immature red blood cells, what we call macrocytes, and a condition known as megaloblastic anemia. Besides pernicious anemia, other causes of vitamin B12 deficiency include surgical removal of the stomach or parts of the small intestine, like in gastric bypass surgery, which removes the sites of intrinsic factor production or B12 absorption. Conditions affecting the small intestine, such as Crohn's disease or celiac disease, can also impair absorption. Strict vegans who do not consume any animal products, meat, fish, eggs, or dairy, and do not take supplements are at risk, because B12 is found almost exclusively in animal-derived foods. Older adults are also at higher risk due to decreased stomach acid production, which is really needed to release B12 from food proteins. The symptoms of vitamin B12 deficiency overlap with other anemias, including fatigue, weakness, pallor, and glossitis, a beefy, red, sore tongue. However, the classic and most dangerous feature of B12 deficiency is the presence of neurological symptoms. Vitamin B12 is crucial for maintaining the myelin sheath that protects nerves. Without it, patients can develop peripheral neuropathy, which starts as tingling and numbness or paresthesias in the hands and feet. They may also experience problems with balance and walking, what we call ataxia, as well as memory loss, confusion, and even dementia. These neurological symptoms can actually become permanent if the deficiency is not treated promptly. The lab workup for pernicious anemia starts with a CBC, which will show a low hemoglobin and a high MCV, indicating macrocytic anemia. The next step is to check the serum vitamin B12 level, which will be low. To confirm that the cause is pernicious anemia specifically, you can test for antibodies against intrinsic factor or parietal cells. These antibodies are present in the majority of people with pernicious anemia. It is crucial to diagnose and treat this condition correctly, because giving folic acid to a patient with an undiagnosed B12 deficiency can improve the anemia, but it will not stop the progression of the irreversible neurological damage. Aplastic anemia is a rare but very serious condition where the bone marrow factory essentially shuts down. It fails to produce enough of all three types of blood cells: red blood cells, white blood cells, and platelets. This is known as pancytopenia. The problem is not a lack of building materials like iron or vitamins. The problem is with the factory itself. The hematopoietic stem cells in the bone marrow are damaged or destroyed. In most cases, this is thought to be an autoimmune disorder where the body's own T cells attack the stem cells. It can also be caused by exposure to certain toxins, radiation, chemotherapy, or some medications, though often the cause is unknown or idiopathic. Because aplastic anemia affects all blood cell lines, the risks and symptoms are widespread and severe. The lack of red blood cells causes anemia, leading to profound fatigue, weakness, pallor, and shortness of breath. The severe shortage of white blood cells, called neutropenia, leaves the body defenseless against infections. Patients can develop frequent, severe, and life-threatening bacterial or fungal infections. The lack of platelets or thrombocytopenia impairs blood clotting, leading to easy bruising, petechiae, which are tiny red or purple spots on the skin, nosebleeds, bleeding gums, and an increased risk of severe internal or external hemorrhage from even minor injuries. The diagnosis of aplastic anemia is suspected when a CBC shows pancytopenia, low levels of hemoglobin, white blood cells, especially neutrophils, and platelets. The red blood cells that are present are usually normal in size and color, meaning normocytic and normochromic. Because the few cells that are made are produced correctly, there just are not enough of them. The reticulocyte count will be extremely low, indicating that the bone marrow is not making new red blood cells. The definitive diagnosis requires a bone marrow aspiration and biopsy. This will show a hypocellular or empty bone marrow, with most of the blood-forming tissue replaced by fat. Treatment for aplastic anemia depends on the severity and the patient's age. It is a medical emergency that requires specialized care from a hematologist. For younger, healthier patients with a severe case, the preferred treatment is a hematopoietic stem cell transplant or bone marrow transplant from a matched sibling or donor. This aims to replace the failed bone marrow with a new, healthy one. For older patients or those without a suitable donor, the main treatment is immunosuppressive therapy. This involves using medications like antithymocyte globulin, or ATG, and cyclosporine to stop the immune system from attacking the bone marrow, allowing the remaining stem cells to recover and start producing blood cells again. Sickle cell anemia is an inherited blood disorder that primarily affects people of African, Mediterranean, and South Asian descent. It is a genetic condition where a mutation causes the body to make an abnormal type of hemoglobin called hemoglobin S, or HbS. Normal red blood cells are round, soft, and flexible, allowing them to travel easily through even the smallest blood vessels. In sickle cell anemia, when red blood cells with HbS release their oxygen, they can change shape, becoming hard, sticky, and C-shaped, like a farm tool called a sickle. These sickled cells are rigid and can get stuck in small blood vessels, blocking blood flow. The blockage of blood vessels by sickled cells is what causes the most significant problems in sickle cell anemia. This blockage prevents oxygen from reaching tissues and organs, leading to episodes of severe pain known as vaso-occlusive crises or pain crises. These crises can affect any part of the body, but they are common in the bones, chest, and abdomen. Over time, this repeated lack of oxygen can cause permanent damage to organs like the lungs, kidneys, spleen, and brain, increasing the risk of acute chest syndrome, stroke, and other life-threatening complications. The sickled red blood cells are also fragile and break apart easily, leading to a chronic hemolytic anemia. The symptoms of sickle cell anemia usually appear in early childhood. Patients experience chronic anemia, which causes fatigue and pallor. They are also prone to jaundice, or yellowing of the skin and eyes, because the rapid breakdown of red blood cells releases a lot of bilirubin. The hallmark of the disease is the recurrent, unpredictable, and excruciating pain crises. Other signs include painful swelling of the hands and feet, called dactylitis, in infants, delayed growth, and an increased susceptibility to serious infections, especially after the spleen becomes damaged and can no longer filter bacteria from the blood effectively. The diagnosis of sickle cell anemia is usually made through newborn screening programs in many countries. A blood test called hemoglobin electrophoresis is the definitive diagnostic tool. It separates the different types of hemoglobin in the blood and will show a high percentage of HbS and very little or no normal hemoglobin A or HbA. A CBC will show a chronic normocytic anemia with a very high reticulocyte count, as the bone marrow works overtime to try and replace the rapidly destroyed sickled cells. A peripheral blood smear will reveal the characteristic sickle-shaped red blood cells. Management is complex and focuses on preventing crises, managing pain, and treating complications. Thalassemia is a group of inherited blood disorders that affect the production of hemoglobin. Hemoglobin is made of two parts, heme, which is iron, and globin chains, which are alpha and beta proteins. In thalassemia, there is a genetic defect that reduces the production of either the alpha or beta globin chains. Thalassemia minor refers to the carrier state, where a person has inherited one defective gene. This is different from thalassemia major, which is a severe disease resulting from inheriting two defective genes. People with thalassemia minor are often called carriers because they can pass the gene to their children, but they typically have a very mild or asymptomatic form of the disease. Individuals with thalassemia minor, whether it is alpha or beta thalassemia, are often discovered incidentally when a routine blood test is done for another reason. Because their bodies produce fewer globin chains, the red blood cells they make are smaller than normal or microcytic. However, unlike an iron deficiency, they usually have a normal or even slightly elevated number of red blood cells. The body tries to compensate for the smaller cell size by making more cells. Most people with thalassemia minor have no symptoms at all, or may experience very mild lifelong anemia that does not impact their quality of life. They live completely normal, healthy lives. The main clinical significance of thalassemia minor is twofold. First, it is crucial to differentiate it from iron deficiency anemia, which is another common cause of microcytic anemia. Misdiagnosing a patient with thalassemia minor as having iron deficiency can lead to unnecessary and potentially harmful iron supplementation. Iron overload can cause damage to the liver and heart. The second point of significance is genetic counseling. If two individuals with thalassemia minor have a child together, there is a 1 in 4 chance with each pregnancy that the child will inherit 2 defective genes and have thalassemia major, a severe and life-threatening form of anemia. The lab findings are the key to distinguishing thalassemia minor from iron deficiency anemia. A CBC will show a low MCV or microcytic anemia, but the red blood cell count or RBC will be normal or high. This discrepancy is a classic clue. Iron studies, serum ferritin, iron, and TIBC will all be normal, which effectively rules out iron deficiency. A calculation called the Menser index, which is MCV divided by RBC count, can be helpful. A value less than 13 is suggestive of thalassemia trait, while a value greater than 13 suggests iron deficiency. The definitive diagnosis is made with hemoglobin electrophoresis, which can identify the abnormal hemoglobin patterns characteristic of beta thalassemia. Alpha thalassemia can be harder to diagnose and may require genetic testing. Mastering the different types of anemia is a high-yield topic for the FNP exam and a crucial skill for primary care. Remember to start your diagnostic thought process with the MCV from the CBC. If it is low or microcytic, your top 2 differentials are iron deficiency anemia, or IDA, and thalassemia minor. To tell them apart, look at the iron studies and the RBC count. In IDA, ferritin is low and the RBC count is low. In thalassemia minor, ferritin is normal and the RBC count is normal or high. A key pearl for IDA is to always investigate the cause of blood loss, especially in men and postmenopausal women. If the MCV is high or macrocytic, your main differentials are folic acid deficiency and vitamin B12 deficiency. Both can cause fatigue and a sore tongue, known as glossitis. The critical differentiator is the presence of neurological symptoms. Tingling, numbness, and balance problems point directly to B12 deficiency. A crucial danger zone is treating a macrocytic anemia with folate without first ruling out a B12 deficiency, as this can mask the anemia while allowing irreversible neurological damage to progress. Always check both levels. Pernicious anemia, an autoimmune cause of B12 deficiency, requires lifelong B12 injections. For normocytic anemias, where the MCV is normal, consider anemia of chronic disease, or ACD. This is common in patients with long-term inflammatory conditions like rheumatoid arthritis or lupus. The lab pearl here is a normal or high ferritin level despite a low serum iron, as the body's iron stores are locked away by inflammation. Treatment focuses on managing the underlying chronic disease. Aplastic anemia is another much rarer cause of normocytic anemia, but it presents as pancytopenia, a shutdown of all cell lines. This is a medical emergency requiring immediate referral to hematology, as the risk of infection and bleeding is extremely high. Finally, understand the inherited hemoglobinopathies. Sickle cell anemia is characterized by HBS, leading to sickled cells, chronic hemolytic anemia, and painful vaso-occlusive crises. A key danger zone is acute chest syndrome, which presents with chest pain, fever, and cough, and requires urgent hospitalization. Thalassemia minor, on the other hand, is a mild, often asymptomatic microcytic anemia that is frequently misdiagnosed as IDA. The clinical pearl is to suspect it when the MCV is low, but the RBC count and iron studies are normal. The main role of the FNP here is to provide education and recommend genetic counseling. By categorizing anemias by their MCV and knowing these key pearls and danger zones, you will be well prepared for your exam and for providing excellent care to your patients.